Hello, everyone, and welcome to another Basana Health and Wellness webinar. My name is Susan Eichhorst. I'm a physician assistant here, and as many of you already know me, and those of you who don't, I am pretty passionate about hormone optimization and how that helps us feel better today, but also age more gracefully. Today, I have had a couple of webinars in the past, one on bioidentical hormone therapy for both men and women, and another on hormone optimization of the thyroid. And you can reference those in our library if you have a desire to do so. Today, I'd like to talk about a different hormone, something that most of us don't even consider or think about unless we're talking about diabetes. This hormone is insulin. Insulin is well known to most people. Type 1 diabetics are people that have autoimmune conditions, and they don't make enough insulin to provide breakdown of glucose. And in those cases, those people would actually die without insulin supplementation. Type 2 diabetes, we use insulin for fairly regularly as a prescribed medication in an attempt to improve blood glucose levels. Before we get into the nitty-gritty of insulin and why I feel this is such an important hormone to educate my patients about, I think I'd like to take a minute to really consider the state of our health in general throughout the world. You know, we're sick by and large. 40% of us in the world's population is overweight or obese. Nearly 75% of Americans over the age of 20 are overweight or obese. 13% of children 2 to 5 years old are obese already, and nearly 20% of our 6-year-old and 19-year-olds have obesity. World obesity rates have nearly tripled in less than 50 years. And prior to 1982, there was not one case of a type 2 diabetic in an adolescent in the United States, probably worldwide, actually. Most of us deal with some chronic conditions or symptoms that we just kind of accept as life. Fatigue, or my joints hurt, my muscles hurt, I don't sleep well, I have headaches, I have digestive issues, I always feel bloated, skin conditions. And we just accept these as, part of getting older. Also, part of getting older is getting some chronic diseases, Alzheimer's or dementia. That's become almost a commonplace for somebody in their 70s or 80s. Cancer, cardiovascular disease, infertility and polycystic ovarian disease in our younger population, and again, obesity, diabetes, arthritis, and non-alcoholic fatty liver. All of these are chronic diseases that, because they are so common, has become almost the norm to accept that this is what's going to happen as I get older. I think the other thing that many of us kind of look at is, what's my family history? And family history is important. I think it is helpful to know what family genes have been passed down, what things are prominent in the family, but consider genetics are what you inherit over the generations through your parents. But epigenetics is how those genes respond to things that you do in your personal behavior. So we now understand through this new science of epigenetics that we can turn genes on and off. We can amplify genes and create good health, or we can create disease, or we can turn them down. We can influence if we gain weight or lose weight. So our family history, in my observation, is really just a snippet into what may happen. But there's a saying in functional medicine, genes load the gun. What you do with them and your behavior is what pulls the trigger. So getting back to diabetes and insulin, many of us will get an annual laboratory with our doctor and be told, okay, you're not diabetic or not even pre-diabetic. And that is great. This diagram shows where these levels are on our normal continuum of lab tests. So anything over 6.5 on a hemoglobin A1C is considered diabetes. But if something is less than that, you may be pre-diabetic and certainly not diabetic if you're under 5.7. Just to refresh, a hemoglobin A1C is a blood test that we use, and it monitors the amount of damage to the hemoglobin in the red blood cell over the course of 3 months. The life of a red blood cell is about 3 months. So that's a good marker for us because we can give a percentage of how many of these cells are affected by too much glucose in the body. So these are really good things to know, but it's insulin that we really also need to be concentrating on because it's now understood that you may never become diabetic, or you may not become diabetic until another 20 or 30 years, but insulin can have an interplay of how your chronic health will develop. So insulin is a hormone that's secreted by your pancreas, which is in your abdominal cavity, in response to eating any sugars or starches. It's the hormone that's responsible for shuttling that sugar from your bloodstream, driving it into the cell so that we can use it for energy. And this also protects having high blood glucose levels in your blood vessels, which can be damaging to tissues in and of itself. Now, after we've eaten something that's sugary or starchy, then that insulin should go back down to normal after eating. But frequently that remains elevated in the bloodstream. And now we have a much better understanding that actually high levels of insulin are just as damaging to tissue as high levels of glucose. So insulin is really an important hormone. We want our insulin to respond and raise up to the level that it needs to so it can push that glucose into the cell. But every single cell in your body and every tissue needs glucose for energy. Now, we'll get into that a little bit later, but we can use some ketones as well, and some people are familiar with a ketogenic diet. But right now, talking about glucose, your brain loves glucose for energy and for neuron growth. Your ears, your heart, your liver uses it and stores fat in the liver at times. Our testicles and ovaries need glucose for normal sex hormone production. And so insulin is something that we will die without, but we've gotten away from haven't really understood how important insulin is to keep at good low levels after eating. This is just a little diagram I thought I'd throw in here to help understand how these hormones work. Today, we're talking about insulin. That's the main character here, but all hormones work in the same way, more or less. There's a lock and key perspective to it. Glucose is taken into the bloodstream through our food, circulating around, stimulates that pancreas to make insulin. Insulin's the little spaceship looking thing over here on the left. And then it fits into that receptor like a lock and key. And that opens the channel in the cell that allows that glucose to get into the cell. This is how most hormones do work as well. The big thing that is important with respect to talking about insulin is then looking at insulin resistance. This is when our bodies become dysregulated in the metabolism from eating too much sugar and starch. The insulin remains high after we've eaten, after it's pushed that glucose into the cell or other tissues like your abdominal cavity. That's where it tends to store as fat, not the fat you can pinch on your belly, the fat you can't touch around your liver and your colon and your heart. That's very highly inflammatory fat, and that's where insulin likes to store extra fat when it can't put that glucose into the cell. The liver can accumulate fat from this process, and even fat cells themselves can continue to grow. Over time, with having these high insulin levels, the cells become desensitized to it, and they just stop responding. This is not uncommon in other aspects too. You keep hearing loud music in the back, eventually you're going to tune it out. Insulin then becomes elevated to such levels that it's also driving its own chronic diseases. So the average American eats about 152 pounds of sugar a year. They also tend to consume around 130 pounds of flour a year. And this is mostly wheat flour. That equates to about a pound of each of these highly inflammatory foods per day per American. Now, of course, that's not everybody, and that certainly may not be a lot of people in my cohort here, because they know that they're trying to take care of or make some changes to their health. But that's the average American. And we do see that in our obesity levels. So sugars and starches, once they become in these amounts, they become poison. And they are really at the root of almost all chronic disease. Just cutting out refined sugar and eliminating processed wheat will probably eliminate about 90% of symptoms and roughly the same amount of chronic disease for many, many people. So I just wanted to include this. This is just another illustration to show you how that insulin fits into the little receptor, opens that the glucose channel, allows the sugar to get into the cell. And then when that's disrupted, all this glucose and extra insulin is staying in the bloodstream. And this is really the conventional model of insulin resistance. There's new theories coming out that, and the reason this can be so important is because then in type 2 diabetics, what we're trying to do is lower the blood glucose in the bloodstream, making this assumption that the cell is starving and that it can't get that energy because it's being inhibited because of the resistance. So what is traditional to do is to give more insulin, raise that insulin level, and force that into the cell. That's not been working. If that had been working, people that are type 2 diabetics that are on insulin should get back to a normal weight if they're utilizing if they're metabolizing their glucose in an effective way. But new theories are emerging that are thinking, maybe we need to look at this a little differently. Maybe it's actually that the cell is not starving, that actually it's an overflow. It's already filled up. It can't take in any more glucose. So the more sugar, the more refined flours I eat, that cell's already filled. The body is resistant to insulin. It's got this blood glucose problem that it's got to solve. So that's where it starts to filter that glucose and convert it into fat, again, in the abdominal cavity, in the liver, and in the fat cells themselves. So now we're starting to think, maybe type 2 diabetes is not being helped at all by adding insulin. In fact, we may be just throwing a little gasoline on the fire, because you add more insulin, you've then increased your need for sugar to balance out the insulin. It's not getting into the cell, and these people continue to get bigger and sicker. So I pulled this little busy slide up here because, again, I want to impress on us that really diabetes is not a good disease, and it has a lot of bad consequences. I spent about 5 years of my early career as a retinal photographer, and the devastations of diabetes is just horrible as far as retinopathy, breaking blood vessels in the eyes, and really devastating people. I saw more type 1 diabetics at that point. This was back in the early 80s, but you saw enough type 2 diabetics back then as well. Now this is a rampant disease. Type 2 diabetics at the end stage also get kidney failure, and they suffer from neuropathy, which can be very painful because it's a neurological condition where the nerves are just inflamed. So that's where we've been concentrating, is really let's find people that are diabetic and pre-diabetic and help them out with that, put them on a medicine. But I want to bring to light that really we need to start concentrating decades sooner. What's happening with insulin? Is this person hyperinsulinemic? If that insulin remains high, it then goes into insulin resistance syndrome. And as you can see down line, it's a major relationship with hypertension, stroke, polycystic ovarian syndrome, which many people equate as a gynecological condition. It happens to have polycystic ovaries in about 50% of the women that develop this. But honestly, 50% of them never have cysts. They never have infertility issues, but they absolutely have insulin resistance. PCOS is insulin resistance, period. That's why people get better when they go on a medication called metformin, because it helps regulate that insulin and or blood glucose levels. But also high insulin levels are associated again with this non-alcoholic fatty liver disease, cancer, and even sleep apnea. So we really need to keep concentrating on how do we get our insulin levels down. The prevalence of insulin resistance is just unbelievable. It's estimated that roughly 85% of Americans, adults, have insulin resistance. The CDC brings to light that 1 out of 5 12 to 18-year-olds now have prediabetes, which is insulin resistance, when 1 out of 4 19 to 34-year-olds have insulin resistance or prediabetes. These are very impactful numbers. These are things that set us up that we're not healthy to begin with. If we develop a virus or we have some kind of a horrible detrimental insult, we may not recover as well as somebody who is insulin sensitive. And these are why this is so important to start checking these and to be mindful and to know you can change things. You don't really need to get a lab test to find out if you're insulin resistant. You can just make some changes and bring that down and avoid it or reverse it. Half of all adults in Mexico, China, and India, these are large countries, are insulin resistant. And more than a third of Europeans and Canadians also suffer from insulin resistance. Again, insulin resistance, most common health disorder worldwide. But it doesn't seem like many people are talking about it. And that's why I'm here today, to bring you up to date. So as I mentioned, we can do some laboratory work. Fasting insulin is a great marker. We like to see levels well under 6 on a fasting insulin level. Fasting glucose has a bigger, wider range, 65 to 99. Really, you're probably better off in that 65, 70, 70-ish range than living right up at 99 all the time. The hemoglobin A1C that I mentioned, less than 5.7% is where we want that. But more like 5 would probably be desirable. The triglyceride to HDL ratio. This is a nice, quick, and easy test that anybody can do from their past labs. Take your triglyceride number, divide it by your HDL number, and that ratio will give you an impression if you have insulin resistance. Some experts will say anything less than 2 is okay. People I follow like to be a little stricter on that, only because we really want things optimized. I don't want a little bit of dementia when I get older. I don't want a little bit of chronic disease. I want to be disease-free. So really, we're looking at levels that are less than 1.5 is really what we're looking at as ideal. And then liver function tests are so impactful because they can help glean out if there's some elevation in liver functions, this ALT, AST, in case you're looking at old labs. We want those well within range, and we certainly don't want them out of range. For females, I like to see them at the low end of the range, more around 20, and because we're a lot more sensitive to outside toxins and whatnot. But if they're elevated, that would warrant that you probably have some fatty liver, and an ultrasound would be helpful to obtain at that point. I want to get back to fasting insulin levels because this is where so many people get confused. And I will say, actually, most of my colleagues get confused on this or just don't know. You know, when we're in medical school, myself, PA school, we're really taught to look at labs, but we're looking at them from a normal or abnormal perspective. And that's great. I respect that people want to be normal. Most of my patients and myself, I want to be optimized. So if you're only looking at lab values, if you get your labs done through Quest, which is a very reputable lab, we use them all the time, they're comfortable by saying your fasting insulin level is just fine if it's less than 19.6. LabCorp gives you a range, 2.6 to 24.9. Really, we want these more or less than 6, as I said. And actually, the lower, the better. I mean, I've talked to I heard from a number of colleagues in their webinars and lectures that I've attended, that they like to see their insulin levels around 1, 2, or 3. You know, you don't need insulin when you don't need it. You need it when the glucose comes on board. So you've got to be able to respond to glucose, but you don't want that insulin to respond when that's not when it's not needed. So lower is better, and just be cautious if you're looking at labs or talking with somebody who's just not familiar with looking at optimization, that lab values are normal. And I think this is a good time to interject something that I bring up pretty frequently with my patients in the office. You know, lab values are really based on a population. They're not based on optimization. Regrettably, they're not the most healthy and optimized of people in that population. So it's a generalized population range. And we do tend to accept, hey, are you healthy? Sure, I don't have any chronic diseases. I haven't been diagnosed with anything. I feel okay. I think I'm healthy. And that's where these levels come from. But when you whittle them way down, anything less than 19.6, if I'm living with an insulin level at 18, I am predestined more than likely to become diabetic if I don't do something about that. And that is very impactful. So just kind of always keep that in mind. What labs are we talking about? What values are we talking about? And are we talking normal or optimal? So why do we focus on glucose and not the insulin? Well, that goes way back. You know, much like much of medicine, we kind of keep building upon what we know, but sometimes we build on the wrong foundation. So the ancient Greeks, way back 3,000 years, they noted that, hey, some of our people pee a lot, very high increased urination. And then sometime later in India, some of those notations